All right, I'm going to set a timer so that I don't talk too long here. I'm so honored to be presenting to you as your keynote today. I wish we could meet in person. I love being able to see the audience and connect with you on a personal level, but the next best thing for now is remote. So I'm happy that we at least have that option today. Today, I'm going to discuss access and barriers among deaf users of American Sign Language in healthcare. During my presentation today, I'm going to discuss the research that was conducted, and I'm also going to tell you some of my journey and my experiences with healthcare and what access has looked like for me personally. Before I proceed, I would like to show you a few pictures. I want you to take a look at those and think about how you feel when you look at them. So on the surface level, this picture looks very nice. It looks like a nice picture of a doctor and a patient getting cozy and discussing a medical concern. It's a nice picture and a nice thought. Unfortunately, I can't relate to this. I can never think about my interactions with a physician being like this. Many deaf people feel the same way that I do. They don't have that personal and private connection with their doctor. There's just no chance that that would be something that I could ever envision for myself. With a sign language interpreter, there's always a third party in the room, and there's often miscommunication, and so much of my attention is put on that communication instead of on the issue I'm there for. So that picture looks great, but it's not necessarily what I experience. My picture looks more like this. In my experience with healthcare, I felt that information is in a fog. I felt frustrated and like I wasn't getting the whole message. This is what many and most of deaf and hard of hearing users of American Sign Language feel when they interact with healthcare professionals, unfortunately. Now I'd like to share my journey and a few of my personal experiences and interactions with the healthcare system during my life. So this is my perspective as a deaf person. My relationship with any healthcare provider takes a laborious amount of effort to ensure that information is getting across appropriately. I have to consider if an interpreter is qualified or not, or if there isn't an interpreter and if the doctor speaks, I have to try to figure out a different way to communicate with them. When I arrive to the clinic for my appointment, I already have a fog looming in my head, thinking about what to expect during that appointment and what that interaction will be like with that medical care provider. I grew up in a small town in Gooding, Idaho. And being a rural town, there were probably only 2,500 people there while I was growing up. It's grown some since then, but it's still quite a small town. And that's where the School for the Deaf resides. As you can imagine, with any small Idaho town, there aren't specialists like pediatricians or primary care physicians. Typically, it's a one catch-all system. So there were only a few doctors in the entire town. So this was the doctor that my family chose growing up for me, and that was Dr. Smith. This was the only picture that I could find of him, and unfortunately, he passed away last year. My parents and my brothers and my sisters and myself all went to the same doctor. The only communication I ever got from this doctor was a thumbs up, a thumb sideways, or a thumbs down. I remember going as a young kid, and I remember him checking my heart rate with a stethoscope, and he would check it and he'd give me a thumbs up. And then he would do various checkups, and he'd give me another thumbs up. And he would press on different parts of my body. And then for communication, he would have me give him a thumbs up, a thumb sideways, or a thumbs down. And at that time, I thought that's how doctors communicated with everyone, including people who could hear. I thought they only used this thumbs up system. So that was my experience growing up, interacting with healthcare professionals. I really didn't have a conversation with him that whole time. When I look back, I think about how much I was missing in those appointments and how much I could have discussed with him. So this was my experience with my primary care physician. So I call him my thumbs up doctor. After I graduated high school, I did not seek healthcare or see a doctor for 9 years. I honestly felt that the system of thumbs up and thumbs down wasn't valuable in my life, and I didn't see that there was a valuable connection there. Fortunately, I was young at the time, and during college, I was mostly healthy, and it wasn't until 9 years later that I found another primary care physician. So my experience growing up, not having communication with my doctor, that caused me to delay my care. And it really wasn't until 9 years later that I took my healthcare seriously. During college, I didn't have a primary care physician, and I also didn't have a dental care provider. It wasn't until I was hired in a full-time position and had healthcare insurance. I realized I hadn't been to the dentist in over 9 years, so I knew I was overdue for an appointment. So I sought out this dentist, Dr. Stephen Ratner. Dr. Ratner is a deaf dentist. I have to say, that experience was amazing. For my first appointment, I remember going in and being able to sign directly with my doctor. When I walked in, the receptionist also knew sign language, and the dental hygienist knew sign language as well. Growing up, my experience going to the dentist was a lot like my experience with the doctor. I would open my mouth and the doctor would put strange metal contraptions in my mouth, and I didn't know what they were for. I just was a good boy and did what they were gesturing and never had any communication with them. It wasn't until I had a deaf dentist that I was able to ask him what all of those metal tools were used for. He was able to explain that one of the tools that they used was for measuring gums. And I asked him about another tool, and he was able to fully explain it to me in American Sign Language. And it was like a light bulb went off. I never had that kind of interaction with a dentist before. At that first appointment with Dr. Ratner, he told me that I had very sensitive gums and that I needed treatment, and I had never known any of that. I did not fully understand dental care and the health of my teeth until this appointment. This was the first time in my life where someone who used American Sign Language could fully explain dental care to me. After that, it made me look back on my experience and think about all that I had missed from my previous appointments. I saw this dentist for several years until I moved back to Idaho, unfortunately, and he stayed on the East Coast. Even though I don't have a deaf dentist here now, because of my experience with Dr. Ratner, I have that built experience and that knowledge that I can draw upon for my current appointments. I've kind of always had bad eyesight. I would say you could call me legally blind as a bat, but I've had glasses since the age of 6. So I've gone to regular optometry appointments ever since then. I remember that they would always pull up this contraption to my eyes and they would puff air into it. And then they would use other contraptions to measure my eye. And I didn't know what it was for. It wasn't until I moved back from Washington, D.C. to Boise, Idaho several years ago when I met Dr. Terry Walker. Dr. Terry Walker is an optometrist who uses sign language. He himself can hear, but he used to be an interpreter, so he's fully fluent in sign language. And it was at that appointment that I could ask him what those measurements were for, what the puff of air was for, and he was able to explain it to me. So I had a wonderful experience with a dentist, with an optometrist, and unfortunately, I haven't had an experience like that with a primary care physician, but I have been able to communicate with them through interpreters, which is the next best thing. But it's because of my experience with Dr. Walker and Dr. Ratner that I had full communication, was able to better understand my healthcare. Unfortunately, Dr. Walker has since moved to Utah a few years ago, which is quite disappointing for me. But I really do cherish the time that I had with him in those appointments where he was able to explain everything to me so clearly. So that is my experience interacting with healthcare professionals. And I'm not alone in this experience, unfortunately. Many deaf people have very similar experiences. And honestly, many of them have experiences that are much worse. So now let's delve into the issue of this: access to healthcare for deaf individuals. I'd like to discuss what the barriers are to healthcare and why those exist. Anecdotally, we have heard stories of people struggling to receive healthcare, but we haven't had the research in the past to show that their stories are valid and that is truly happening on a larger scale. When I moved to Boise, I accepted the job as the executive director at the Idaho Council for the Deaf and Hard of Hearing. Within that, we address many issues that deaf and hard of hearing people experience, and one of those that we address often is access to healthcare. At our office, we have received many complaints and concerns from community members expressing their issues with access, whether that be in regards to interpreters or other issues. And we've noticed a pattern that many of those issues are related to access to healthcare. Since 2008, when I started working here, we've received many complaints that clinics and offices wouldn't provide interpreters, and we have done outreach and education to inform them regarding the laws that pertain to them. We also began collecting data on how often we receive these complaints, starting in 2012. We collected this data for 5 years. During that 5-year period, we collected 108 complaints related to healthcare. We know that these aren't the only issues across the state, that there are many that go unreported that we're unaware of here at our office, so we can't provide our assistance. I want to thank Idaho State University and their research analyst who helped us to analyze this data and to recognize this trend and this issue that people were experiencing in regards to healthcare. I'll now explain a few of the instances that, a few of the complaints that we received. I'll share 3 stories of actual complaints that happened here in Idaho. Again, there were many that we received, 108, but I'm just picking 3 to highlight today. This specific complaint occurred in Nampa. There was a clinic that would not provide a sign language interpreter to a deaf patient for many months. That patient's family decided to transfer their care to another clinic where an interpreter was provided. Before that, the patient had been misdiagnosed many times, and it wasn't until they transferred care that they finally received the correct medication and the correct treatment to help them recover. This is a common issue. Here's another instance of one of the complaints we received. This happened in Meridian, Idaho, so just outside of Boise. In this instance, the mother of the patient was deaf and the child could hear. And this mom who was deaf felt that there was something wrong with her child, and so she took her in to be seen at the clinic. But they would not provide a sign language interpreter. And this mother tried to explain the issues that she knew that her daughter was experiencing, but the doctor took a look at the patient and said, well, it could be this, or it could be this. But because they would not provide a sign language interpreter, the deaf mother did not have access to this. It wasn't until her child's situation progressed that they had to go to the emergency room, where they finally provided a sign language interpreter. And the mother was able to express the entire experience. And it wasn't until that ER visit that they were able to discover what was wrong, and they were able to prescribe the treatment that was a life-saving measure. This third complaint was received from an instance in Twin Falls, Idaho. The patient went in complaining of lower abdominal pain and needed to have an appendectomy. There was not an interpreter provided for this surgery, so they were rushed off to surgery and then released. And it wasn't until they woke up that the deaf patient lifted their gown and tried to look for the incision wound, but only saw a very small piece of tape on their stomach. There was no one that explained to them what the surgery was before they arrived. And it wasn't until after they were discharged that they got home and they wondered if a surgery had even been performed. So they were able to call through video relay service, and the healthcare provider explained that they were able to remove the appendix through a small incision in the navel. So they weren't going to have a big scar on their stomach. Unfortunately, none of this was explained to the patient beforehand. Instead of the doctor taking time in that instance to explain the situation to the patient, they just waved them off and discharged them. So these are just a few examples of the complaints that we received in our office during that 5-year period. Here is an analysis of those 108 complaints that we received. Of those 108 complaints, approximately half said that when they called to request an interpreter, the office would provide them. However, approximately half of these, once they arrived, there was an issue regarding the interpreter. The other half, the 48.2%, when they requested an interpreter, the office said that there wasn't an interpreter available, and they took no precautions in order to secure an interpreter for that appointment. Another statistic shows that almost 29% of these offices said that they would provide an interpreter, but upon arrival, there was no interpreter provided. Upon arrival, the interpreter that was provided was not qualified and was incompetent. In 18.5% of these complaints, there was an interpreter promised, but there was not one provided upon arrival. 4.6% of the time, the patient was told by the clinic that their insurance was not accepted. The patient felt that this was an excuse for not providing an interpreter. Instead of telling them that they wouldn't provide an interpreter, they believed that the clinic just told them that their insurance wasn't accepted, even though it probably would have been. They were also told that they were not accepting new patients. From this research, we shared our findings with Dr. Elizabeth Schniedewind. And from that, we were able to establish a new research project, a simulated patient study, to really delve into the issues that we received from these complaints. We worked with a wonderful team, including Dr. Schniedewind. She was the lead researcher on this program. Dr. Ryan Lindsay, who is well-versed in numbers and analysis, also worked on this project. And this was published in the Journal of American Medicine Association, which was a huge accomplishment. I'm not going to delve into too many of the details, but I'd like to share with you a few instances of the study and the results that we found. Now I'll explain the design of this study to give you an idea of how it all got started. Once we decided to conduct this study, we knew that we needed to collect a sampling group of doctors' offices and dental offices. So what we did is we collected a list of licensed primary care physicians and a list of primary dental care providers. For this specific study, we decided to focus only on primary care physicians and dental offices instead of on specialists and other offices. So from that, we collected a stratified random sample of 445 providers. 75% were primary care providers and 25% were dental care providers. At that point, we selected a total of 8 simulated patients or research assistants. Of those 8, 4 of the individuals were deaf and 4 could hear. Of the deaf simulated patients, 2 were male and 2 were female. And of the patients who could hear, 2 were male and 2 were female as well. We then asked these simulated patients to call all 445 clinics to request a new patient appointment. These simulated patients are also referred to research assistants. We gave these research assistants a script that they would use when they called to request a new patient appointment. The only difference between these two groups was that the deaf simulated patients used the video relay service to call through a sign language interpreter when making these appointments. All of those calls that were made by the deaf patients were recorded, both video and audio, and the audio was also recorded for the simulated patients who could hear. The total number of calls that were made was 1,092. So you may be wondering why we only had 445 clinics, but 1,092 calls. The reason for that was because the research assistants had to make several follow-up calls in order to attempt to secure an appointment. We also ensured that all of the research assistants had a phone number that was a 208 area code. The reason for this being that if they had an area code that was in California, for example, they may be screened out of that initial process by the person who's working the phone at the office because they might have thought it was a scam call. So because it was a 208 number, we thought for sure that it would get through that first initial screening process. Now I'll show a map of where those clinics were selected across Idaho. As you may have guessed, most of the clinics that were selected were in the Treasure Valley. The remainder of the clinics are along what we call the Banana Belt, so Twin Falls and Idaho Falls, and we also included clinics in northern Idaho. Within that, we had 3 demographic locations: urban, rural, and the final category was frontier. So these refer to those very small towns in the middle of the mountains, really in the middle of nowhere. So beyond rural, but frontier. So those were the demographics that we selected. So after we had the research assistants make those calls, what did we learn? Not to our surprise, we found that deaf patients were less likely to secure a new patient appointment than patients who could hear. And this is something that we have heard about for years within the community. But through this research, we finally had the data to support their claims. It wasn't just a few people making noise, but now we have the data to show that deaf people are being discriminated in this realm. With this research, we found that the anecdotal data and this data through this research project coincide. We found that patients who can hear were almost 2 times more likely to be successful in securing a new patient appointment than patients who were deaf. One interesting thing that we found through this research project was actually through one of the research assistants who is deaf and actually happens to be my wife. So at the conclusion of this research, my wife felt very angry and very emotional. And I remember her coming to me at the end of the day and asking, why would they do that to us? Why would they discriminate against us in that way? And I tried to help her feel better by explaining, we're just going through this for the research project. But she really took it to heart and it felt very personal. And we spoke with the other 3 deaf research assistants in this project, and they all had that same reaction. Through this research, we found that approximately 48% of these failed appointments occurred because these deaf patients requested a sign language interpreter. So approximately half of the time, the reason why they were denied an appointment was because they had requested access. Here's another interesting finding from our research. Historically, we have always encouraged deaf individuals to practice self-advocacy. This means that we've encouraged them to request an interpreter and to continue to educate those clinics when they're requesting an appointment. During our research, those research assistants made follow-up calls to request an interpreter, and we found that the more times they called, the less likely they were to be successful in securing an appointment. We found that when they would initially call and request an appointment, they might have been granted one, but then if they followed up by saying, by the way, I need an interpreter, the staff person that they spoke to often made an excuse and would cancel the appointment. We know that the deaf community has to self-advocate in so many realms. So to have to do it again in the medical setting for it not even to be successful is so exhausting. Another interesting finding, which may be quite surprising and honestly, maybe a little disgusting, is this. Our research found that even though our simulated patients who were deaf and our simulated patients who could hear had the exact same insurance, when our patients would call, oftentimes the hearing patient's insurance would be accepted, but the deaf patients were told that their insurance wasn't accepted, even though this insurance was the exact same and they were calling the exact same clinics. This means that those clinics were trying to hide their act of discrimination by making up the excuse that they didn't accept the insurance. So our research shows that it really isn't that they don't accept the insurance, but it's truly just a blatant act of discrimination. I could delve into so much more on this research, but I won't keep you too long. I know that you all aren't researchers, but I just want to give you an idea of those findings that were quite surprising from our research. Or excuse me, it honestly was not that surprising because we've seen that happen again and again through those stories that we've heard. Another study that was conducted by the National Institute of Technology for the Deaf and the University of Michigan found this. This research by NTID and the University of Michigan found that deaf individuals are 7 times more likely than their hearing peers to have heart disease, high blood pressure, and strokes. This is just shocking. When I look at this, I try to think why, and I have some thoughts as to why it could be, but we really need to conduct more research to show that our inklings and our feelings as to why are true. That hasn't been conducted to this point, but we're hoping that more research will be done in the future. This is heartbreaking that deaf individuals like myself are 7 times more susceptible to heart disease, high blood pressure, and strokes. This shows that something is wrong with the system. I'd like to share another image with you at this point. I want you to imagine this iceberg as the deaf community interacting with the healthcare system. As you can probably guess, of the deaf community, everyone has their individualized experience with healthcare, with the healthcare system, but I've categorized them into 4 categories. The first category, the very tip of the iceberg and the cream of the crop, which is, as you can see on this picture, a very small percentage. It's this percentage that have complete access to their health care. It could be that they see a physician who signs, or that the clinic is well versed in interacting with deaf patients, and they have a very qualified staff of sign language interpreters. It's only a small percentage of deaf people who have this perfect access to their healthcare. The second group represents the larger portion of the iceberg that is above the surface. And this is people like me. I've had experiences with appointments where the interpreter is incompetent and unqualified. I've had experiences where I've tried to interact with my doctor without an interpreter. It may be that I have had to fight for them to provide an interpreter, and they finally have, but it's not without its struggles. So that is another percentage. And then the third group is that group that is below the surface. This is the group that we often don't see. And this is the group that our research primarily focused on those who requested appointments, but were often denied. This is the group of deaf individuals who have been denied interpreters and have had to try to go to these appointments and just get by with what they can, or have just taken what they can get from the doctor's office, even though they won't provide accommodations. Instead of fighting the system, they haven't had the education in order to maneuver that, to move their way up above the surface and into that second category. The fourth category are those that say, why bother? And this is very saddening. And that's the group that breaks my heart. These are the people that would rather suffer with their pain than have to try to navigate the healthcare system. They know that it's not going to be worth their effort, so they don't even try. I was a part of this category when I didn't have a physician for 9 years after high school. I didn't think it was worth it. And I would say that the largest percentage of people are in this category. They feel that pursuing healthcare is not worth it. They would rather live with their pain and live with their problems than seek care. And it's this category that relates to that research that was conducted by the National Institute of Technology for the Deaf that shows that deaf individuals are 7 times more susceptible to healthcare issues. Deaf individuals, myself included, deserve to be accepted as patients. There's no question about that. We deserve to have full access and full communication with our healthcare providers. It shouldn't have to be a battle, and it shouldn't have to be something we have to navigate through. Our system needs to change. And there are many possible solutions. One being training. And we have conducted some trainings with some medical schools, but more needs to be done. There are many possible solutions for this issue. From my perspective, the best solution, and probably the long-term solution that will take the most work, is well summarized in a quote from my good friend. This quote says, "The first law of medicine is to do no harm." Don't we realize that by not providing proper communication access to those that need it, we end up unintentionally harming them? Hence, the dire need of diverse physicians, including deaf physicians. If we had more deaf doctors and more doctors who could hear but could sign, more doctors like Dr. Walker and Dr. Ratner, that would change the experience for many deaf and hard of hearing patients. There's no question about that. I want to again say thank you for this opportunity to present on this research that was conducted. I'm hoping that this research that was printed in JAMA will then lead to further research, and we're able to take a deeper dive into those levels of that iceberg. There's so much more under the surface that's just waiting to be discovered. And there are many layers to this issue. I'm hoping that through that research, we can begin to see a systematic change in the healthcare system. So this concludes my presentation, and now I'm open to any questions.
Well, I first want to say thank you so much. That was very informative. And I think that shock-faced GIF gave my reaction perfectly. To recognize that there's a 2-to-1 ratio in securing an appointment, and that's a huge discrepancy.
Absolutely, yes. Yes, is very unfortunate.
And so there was one question that came in regarding the patient that had the appendectomy. And that question was, wouldn't the patient need to sign an informed consent for surgery, provided that they were awake and alert?
Well, that's a great question. And this actually brings up a very serious issue. Many deaf patients are handed written instructions and they're told to sign them. And so they just sign where they see the X on the paper without even reading it. I would say a large percentage of those people who do that don't know what they're signing. If clinics would take the time to interact with their patient and say, will you sign this? But before you do, will you tell me what this means? That is so critical to ensure that their patient understands what they're signing before doing so. What we see happen so often is that someone just shoves the clipboard in front of them and says, we need you to sign this right now, instead of actually taking the time to ensure that their patient fully is aware and understands that information.
Here's another question. What can hearing individuals who work at the bottom level, such as receptionists, do to aid deaf and hard of hearing individuals in the workplace and specifically the medical field?
All right. Would you mind repeating that question? I'm sorry, the chat popped up right over the interpreter as you were asking that.
What can receptionists do if they're the ones answering the phone to help the deaf and hard of hearing individuals?
Again, that's another great question. It's important that all clinics have a set protocol and guidelines for these receptionists. So for example, they should have it in writing on how these receptionists can accommodate and provide these accommodations like sign language interpreters. One of the greatest issues that we see is that there is a high turnover rate for these frontline staff. Instead of having to reestablish a protocol every time someone is hired, the clinic should have a set of guidelines that an individual can refer to when they receive a call from a deaf patient. This way, when a deaf patient calls, they can just flip to the right page of that protocol and they're able to accommodate them. Some clinics have those and some do not. We've noticed that typically larger systems that have multiple clinics have this set of procedures, but most small independent clinics do not have this yet. It requires awareness and training at the higher levels in order to establish something like this, but we highly encourage that people do that.
So for those frontier physicians' offices, what resources are available to provide interpreters if there aren't any that live in the vicinity?
From my experience with those frontier offices, we've only had a few of them, maybe 2 or 3 that have reached out to us to help them resolve that issue. Fortunately, with technology these days, we have options like video remote interpreting. So if an interpreter is not anywhere within a 100-mile radius, these clinics would be able to connect through a sign language interpreter through video capabilities. I do want to caution everyone, though, that that is not befitting for every situation, but in some situations that is a workaround.
So have you seen clinics or hospitals utilize tablets or whiteboards to communicate? And what's the effectiveness of that strategy?
Yes. Well, my answer is it depends. I would say that clinics should not assume that deaf individuals can read and write English. For many people who are deaf, English is their second language. Especially when we're considering healthcare, when an individual is entering an environment that is quite intimidating. They're already in pain and they already are so focused on that they are less able to concentrate on trying to communicate in their second language. And that's why providing a sign language interpreter is such a great accommodation. I also want to remind everyone that access is not a one-size-fits-all, and it's not a one-way communication. An interpreter is provided for the deaf person to be able to understand, and it's also provided for the healthcare individual to be able to understand as well. So it's not just that the information is being passed from the healthcare provider to the deaf patient, but it goes the other way too, from the deaf patient to the healthcare provider. So when clinics are considering what accommodations to provide, I want them to consider that communication needs to go both ways. It needs to be a two-way street. And so the accommodation of a sign language interpreter would be the most effective way.
And here's our final question. I want to be a nurse. Is it worth learning ASL, even if I'm not at an interpreter level of communicating?
Wow. I'm so glad that someone brought that up. I was planning to mention that during my presentation, and I don't think I did. So that's a great question. In our audience today, we have several students in various fields within the healthcare setting. If I could communicate with you directly as a patient, that would make my day. That would be the best option. And even though you may not be equivalent to an interpreter, I would encourage you to take several classes. So it's not just the basic ABCs that you know, but I would encourage you to take those classes and to get involved with the deaf community. It will open your world. And that will help you develop a wonderful rapport with your deaf patients. I highly encourage, if you're able to take sign language classes. If you have the time, 100% do it. I do want to say that with a caveat, that if you are still learning sign language and you may know some basic signs, still provide a sign language interpreter. Still bring in that person who's fluent. So then you're not gambling on anything. And it may be that from then on, after having that interpreter there one time, then we can communicate directly.
I want to thank you very much, Stephen Snow, for your presentation. And we are going to take a break and restart at 2 o'clock. You will see a poll show up. And so please, those of you who are participating, complete that poll, take your break, and we'll see you in 5 minutes.
Wonderful, thank you.
All right. So wanted to thank Jill for her thoughts and her comments. And I think she was able to wrap things very well for us. So one of the first questions, and I'll take this one, is how do we reach you? And so at the end of our conference today, we will send out contact information, and we'll make sure that on your the agenda, conference agenda, we'll have email addresses on there as well. So, and there are a couple of thank yous in the Q&A that I wanted to recognize. So one question is, how can interpreters make an impact for deaf and hard of hearing students and their right to full access, especially for kids who may not have that language background and don't know how to access through an interpreter? Jill, would you like to take that question?
I'm going to read the question in English to ensure that I'm addressing all of it, if you'll give me just a moment. I'm going to give you my utopian answer with Stephen Stubbs here, as well as our qualified interpreters. My perfect vision of education would be to have both a certified hearing interpreter as well as a certified deaf interpreter in a classroom with deaf kids the whole way through. So that's a utopian answer. It's not realistic necessarily. But I know that the role of an educational interpreter is critical, and interpreters need to possess cultural knowledge. That's true both of educational as well as community interpreters. Students who are deaf and hard of hearing in a classroom often struggle with accessing full information and all of the culturally rich information in the educational setting. An educational interpreter is part of the individual education plan team, the group that develops the IEP and recognizes what's necessary to help students fully develop and thrive. Educational interpreters have a role to provide input as an expert in the classroom for educational settings. So that's my thoughts on it.
I'd be glad to add to that. When we look at the word full access in all caps, when I think about that, I think about the classroom environment with a student sitting and an interpreter there. Now, there is passing periods where students have these opportunities to find out what they've done over the weekend, and a deaf student may not have that. People communicate in the cafeteria, and the student would not have that full inclusion. Often, the IEP team, the Individualized Education Plan team, just focuses on this academic and classroom environment. But what they fail to consider is the other activities, the between classes, the cafeteria, the interactions with the friends and after school extracurricular activities. So
Yes.
when we're talking about full inclusion, I'm so thankful that I had my experience at the residential school for the deaf. I wasn't in Idaho, I was in another state. However, when I was done with class, I could talk with my peers, make plans, joke with them, talk to them in the cafeteria. And really, it was just one big wild party all the time. But I was involved after school in sports. And so I had this opportunity to develop relationships, to learn problem-solving skills, to develop a sense of self-identity, all of those other things that when you think of the word full inclusion, do they really mean full inclusion, or do they just mean inclusion in the classroom?
Thank you. Snow.
Absolutely. There are two things that I would like to add to that as well. It's important that educational interpreters set aside their pride and that they attend workshops and they continue to hone in on their skills.
Absolutely.
Unfortunately, what we see is that many educational interpreters feel that they are competent enough and they don't participate in trainings and they're not involved in the community. And secondly, Stephen Stubbs mentioned the word full access. And it's scary but true. In Idaho, the way that we qualify an educational interpreter is through the Educational Performance Assessment, or the EIPA. And that minimum score to work in the state of Idaho is a 3.5 on that assessment. And that is equivalent to 60% of the message, which means that the interpreter is listening to 100% and only interpreting 60% of the message. And do we consider that acceptable? Meaning that our deaf students are only having access to 60% of their education. If we think about it, 60% isn't a full access to education. Even a 4.0 is still not at that 100% accessible level. It's impossible for a student to be able to fully access their education through a sign language interpreter. They can get close, but it will never be 100%. It's imperative that educational interpreters analyze themselves and that they be honest with themselves about their skill level. Instead of pushing those concerns aside, if they're concerned in some areas, they should be honest and upfront, and they may need to step aside in some situations and have someone else step in to interpret. Many interpreters say that they are good enough and they don't take the time to analyze themselves, so it's imperative that educational interpreters do that.
And that applies to medical interpreters as well. Any situation, really, any type of interpreter, not only educational. Every interpreter needs to know that when they are walking in to an appointment, and I can think how often interpreters may be thinking like, ooh, that's me or that's me. But for a deaf person to have full access, that's not realistic unless the person they're talking to is also using sign language.
So along those lines, what is the best way to establish or reestablish trust with a deaf client when an interpretation has not gone smoothly? And this is from an interpreting student.
I can take a stab at that. That is an issue that we have in one of our classes, in an ethics class, that we focus on really that sort of thing for an entire semester. And it's still just scratching the surface, but really there's two ways to look at it. You can think about the perspective with whether or not the interpreter is transparent with the deaf client. So if they've arrived at an appointment and they say that I'm a novice interpreter or I'm new, and they try to work things out, and they say, if I'm not going to be okay, just let me know and we'll reschedule. You can take a look at that way. Or also, we can take a look at what the deaf person needs. Perhaps it's an emotionally charged appointment, and they know that that interpreter is not appropriate for that situation. But there are those situations that are not that sort. There's a range of situations, and there's a range of interpreters, and sometimes they're layered and they can overlap. One has to think about how to solve that, and it can be discussed at length, but we do actually discuss that for those sorts of things for an entire semester with interpreters.
I'd also want to say in regards to trust, or we're still on that question, correct?
Yes.
Just in regards to trust, I would say that first impressions are long lasting.
Yes.
So when that trust is lost, I would say good luck trying to earn that back. It's very difficult to do. And the deaf community is very forgiving, but it's something that you all should keep in mind, that if that trust is broken and if you have been negligent with that, it's really hard to regain that. We know that interpreters are human, and we will always consider that. There are some situations that are highly sensitive, though, and if an interpreter does come in and breaks that trust, it's very difficult to earn that back. So I would say do it right the first time. Don't make that mistake.
Yes.
I have something else. I saw another question that was in regards to music, a person who had said that they were a music educator. And I thought that that might be, they're talking about accommodating deaf and hard of hearing students. I have to tell you, there are many deaf people who love music. Indeed, there are.
I'm
Yeah,
one of them. I love it.
especially, well, except me. I don't know. I can't, well, okay, no, not me, but
I
because I
love,
can't hear
love,
it, so I
love,
hate
love,
it.
love
But
it.
there are people who do.
Jill's not normal. Just ignore that.
Anything else you want to add about how, let's see where that question went. How to include those that want to experience music in the classroom?
No, I want to go first, not me, or not Steve. I want to go first. Okay.
Yep.
So in American Sign Language, it incorporates both rhythm and rhyme. Many people don't realize that American Sign Language can incorporate the concept of a beat or of rhythm, that those things are already a part of the language when well done. So if you find someone who is a qualified language model who is doing it well, whether it's music or poetry, there's so many videos that are available now that you're able to show, and that you can see authentic native signers, and they are producing music from American Sign Language, not an interpretation of English music for people who can hear or other languages for people who can hear, but rather deaf poetry, deaf rhythm. Many schools think, oh, we should include sign language. It's so pretty. It'll be very pretty for this song. I would say be careful with that. It is easy to misunderstand how to incorporate signs. Sometimes they're applied incorrectly to English lyrics. So if the goal is just make it a pretty performance, I would caution people against that. So as somebody who is a native signer, I would say bring in somebody who knows ASL. Don't rely on videos for vocabulary.
Absolutely. Another resource that could be used for students or for teachers is called DPAN, DPAN, and that can be found on their website or on YouTube. And they have several videos of music in American Sign Language. One individual, his name is Sean Forbes. I'm not necessarily his biggest fan, but I know he's very popular in that realm. And he makes many videos that are very visually appealing, that incorporate those sounds in a visual way. And I wouldn't say many, but some individuals really like that. So that's another option to incorporate music in a visual way.
Thank you. All right, I have one for you, Steve Snow. From earlier, thanking you for your research and the work that went into that. And this individual loves the idea of diversity in the medical field. However, they have witnessed and know of many deaf individuals who have tried to complete a medical program. So as the student, a medical program, but the amount of discrimination they face in these programs is a huge obstacle. So how do we educate the educators?
Absolutely. That's a great question. One of my good friends, Zach Featherstone, he is well recognized nationally for his case of discrimination when he was in medical school. And the National Association of the Deaf actually sued that medical school and won that case. At that point, Dr. Featherstone decided to transfer schools and completed his training there. There are many deaf individuals, like this person asked, that have experienced that and have experienced discrimination to the point where they have not finished. From what I have heard, even after they have submitted a complaint of discrimination, they're often neglected and excused from that program, saying that they don't qualify to finish. There are quite a few deaf students who are currently in the process of going through medical school, so it's promising, but there definitely needs to be more awareness and more instruction for those educators. Unfortunately, autism is rampant in the medical field and in that culture. And what that means is that they are focused on the ear only instead of on the person as an individual. I've noticed some cultural shifts and some minute changes, and I'm hoping that we continue to see that. There are so many competent deaf individuals who can be successful if they choose to enter the medical field. And who knows, one day they could even find cures for horrific diseases, but we need to be able to give them the opportunity to become a doctor first.
If I could chime in with that, we've talked about autism. Doctors and medical professionals often suffer from ableism. They see everything as something broken that must be fixed. I would encourage them to look at it through a different framework. Just look at multiple abilities. So instead of looking at what people cannot do, focus on what they are able to do. When people go in to see a medical professional, they come in with skills, with knowledge, with ability. They aren't coming in as something broken to be fixed. Zach Featherstone's approach in his case are something that the deaf community really celebrated. The deaf community, it feels like one of our own is now in the field that we could get full access. I think, as Steve said, change is coming. You will see a tidal wave of change.
Absolutely. For our participants today that are entering the medical field, I would encourage you to do your part. We can partner together to make that change. Instead of just taking today as just some neat information, you can take this on and apply it to the medical field.
Yes. Often parents meet a doctor as one of their first professionals after they find out that they have a child who's deaf and hard of hearing. They don't know where to find deaf adults, and that's not who they go to first. They trust the medical providers, and so they'll go to the doctor or audiologist and say, hey, I have this deaf kid. What can I do? And I think that this is where medical providers can really establish a rapport with the deaf community, and we're seeing that happen more and more. That change is coming.
So one last comment here. Two. One is a thank you for bringing up the idea of 60% with the EIPA. And the other is that hopefully this is the tipping point. And just a big thank you for sharing all of this vital information. And so with that, I'll give a couple of concluding remarks. And so if I'm going to share my screen again, if our panelists want to turn off their videos, thank you again so very much.